Hello, I'm Dr. Lisa VanWagner from Northwestern University in Chicago, and I'm here today with Dr. Cameron Fairfield, who is a clinical research fellow for the for Medical Informatics at the Usher Institute at the University of Edinburgh. And this is part of the Clinical Liver Disease video series. Clinical Liver Disease, of course, is a multimedia journal that is published on behalf of the American Association for the Study of Liver Disease. And Dr. Fairfield is here today to talk about his recently published article called Steroid-Free versus Steroid-Containing Immunosuppression for Liver Transplant Recipients, which is part of CLD's new series called Evidence to Practice, which summarizes systematic reviews for practicing clinicians. So, Dr. Fairfield, thank you so much for joining me today.
Great, thank you. Thank you very much for inviting me to take part.
Excellent. So can you tell me a little bit about why did you and your co-authors decide to conduct a systematic review on this topic?
Well, over the past 20 years or so, there's been a number of novel agents that have come onto the market in terms of immunosuppressants, which have really enabled us to change the whole protocol when it comes to immunosuppression for liver transplant patients. So things such as tacrolimus, sirolimus, mycophenolate, and various induction agents such as basiliximab. And because of those agents, there's been a general trend to less acute rejection in liver transplant patients. And that has led a number of authors to think, well, perhaps we could reduce the steroids, the corticosteroids that used to be the kind of mainstay of immunosuppression. And they obviously have a particularly well-known adverse effect profile. And perhaps with all these new agents which have entered the market, it's possible to either completely avoid them or at least minimize the role that they need to play. So we performed the systematic review and meta-analysis looking at some of the randomized trials that had come out assessing that very question.
Okay, so the focus was on whether or not you could either take steroids away completely or whether you could just reduce steroids and potentially impact on clinical outcomes. So what were the main clinical outcomes that you were looking at in this systematic review?
So there were four primary outcomes that we looked at, and those were mortality, graft loss, including mortality, acute rejection, and infection. And then we also had a number of secondary outcomes that we looked at as well, some of the kind of well-known adverse effects from steroids themselves, as well as some of the additional adverse effects from immunosuppression in general.
Gotcha, like cardiovascular effects and diabetes, those kind of things.
Yeah, diabetes, hyperlipidemia, all of that kind of thing.
Okay, and what did you find?
So we found a number of things. So if you looked at trials that had reduced and in the steroid reduction arm, we found that there was a slight increase in acute rejection. There was also a slight increase in steroid-resistant acute rejection. However, the flip side of that was there was a slight reduction in diabetes, a slight reduction in hyperlipidemia, and no overall effect on graft loss or survival that we were able to detect.
Excellent. So what do you think the clinical take-home message is? What should the practicing clinician take away? Would this change their clinical practice? Or should this change their clinical practice?
Yeah, I suppose it depends on what your current immunosuppression protocol is. I think what we've shown quite clearly is that steroids have well-known side effects, and that removing steroids from the equation, or at least reducing the level of steroids that you use, will obviously reduce those adverse effects like diabetes and hyperlipidemia. And that is probably a good argument against long-term steroid use and in favor of a tapering regime. However, we have shown that there is an added risk of acute rejection, and that perhaps favors a tapering regime rather than total avoidance. Although what I will say is the systematic review and all the evidence we were able to pull doesn't quite give us enough data to say where that boundary line is. You know, is that a month of steroids? Is it 3 months of steroids? What dose is that? That's the kind of thing we don't know from our data.
Great. That's the tough part, right? So I guess what would you say is the next step in order to move this field forward?
So we feel that one of the things that could benefit the transplant community is a high-powered 3-arm trial, which assesses that exact question, looking at complete steroid avoidance in one arm, a short tapered regime in the second arm, and a longer tapered regime in the third arm. And one of the benefits of doing that in a single high-powered trial is it removes the effect of all heterogeneity and all of the other aspects of transplant management, which obviously hinders the interpretation of our current meta-analysis.
Great. Well, so important and such an important question. And thank you for publishing this. And the original article was published in the Cochrane database and Cochrane reviews. And so incredibly high quality methodology that you and your co-authors use. So thank you so much for summarizing it for us. If you want to learn more, you can read the full article at Clinical Liver Disease Journal, and you can go to cldlearning.com. Thank you.